diagnosed each year. And you can see that cancer, from this graph, you can see that cancer, of course, is affecting people more in older years. So as we get older, our risk to be diagnosed with cancer increases. And all of these first few slides that I'll show you today try to highlight or try to bring you into the view of what a typical carer might look like. So given that most people who develop cancer are older, their carers are most likely also in the maybe older age groups. It could be that some people are cared for by children as well, but most commonly it's more the same generation that will get involved in the care of people. Cancer is it's one of the leading burdens of disease causes in Australia. It carries about 19% of the total disease burden that we have in Australia, and over 500,000 disability-adjusted life years are caused by cancer. So a very, very big burden in Australia through cancer. And that's, I guess, why we are here today to talk about this in more detail. It's a significant issue for everyone in Australia. So among Indigenous people, and I guess that will have been talked about yesterday quite a bit, is that cancer is somewhat less common, however mortality is higher, and that's something that we need to address. So given those really big numbers of cancer survivors in Australia, almost everyone will know someone who has cancer, and almost everyone will be touched by cancer in one way or the other in their lives in Australia. However, each of the stories differ. This is the very recent Australian Bureau of Statistics data that looks at just more general the self-reported overall health of Indigenous and Aboriginal Torres Strait Islander people. And if you just look at this again from the perspective of who will be the people who will care for someone who is diagnosed with cancer, you can see that about 40% or so of people say that their own health is excellent to very good. About 40% or so say that their own health is good, but you can see that quite a significant proportion of people report that their own health is fair to poor. So if those people then come into the situation that they have to care for someone else, that could be quite a significant challenge. So we have to keep in mind that the carer also might be facing quite significant health challenges themselves, and that is something that we need to assess carefully. What's happening with the carer? Is the carer actually in a good enough condition to provide supportive care that the patient needs in this situation? And that's a quite typical story that you hear when you ask carers. Well, they will tell you very often that it's tough for them to care for their patient with cancer because they themselves also have heart disease, problems with diabetes. They go through various life events themselves, so we have to keep that in mind. So this, especially those people that themselves have fair to poor health, if we ask them to care, that could be a significant challenge. This is the health risks, and as I said, our group is really very interested in not only supportive care, but also prevention, because in my view, any cancer that we can prevent is a fantastic thing. So preventing cancer is something that's really, really important, and several of the brochures out there are targeted towards preventing cancer. So with regards to one of the health risks, here we have, again from the ABS, the obesity rates by sex and age of Aboriginal and Torres Strait Islander people. And you can see that while young people, the proportion is relatively low, you can see as we get older, the proportion of people who are obese increases. And actually the proportion obese in the older age range is really very high. So I think that's something that's important to keep in mind, again, with regards to preventing cancer, because obesity is a risk factor for a number of cancers, especially endometrial cancer, colorectal cancer, breast cancer, and so on. But also when we look at it from the perspective of the carer, if a person is obese, it will be more difficult to do all the intensive tasks, the driving around, the lots of activities that people have to do. It will be harder for those people to care. So the next one is exercise level. Again, something that's very important with regard to preventive health, and also with regards to the stamina, I guess, that a carer might have. So you can see again with regards to exercise levels that we have quite a proportion of Aboriginal and Torres Strait Islander people who report that they are completely sedentary, so they don't do any exercise at all. And that's a really big problem that I guess we have to look towards, and also something that we should assess in our carers, because doing some exercise can also be helpful for the carers to feel better themselves, and can also relieve them from the stress that they experience when they are caring. If you go for a walk, for example, or if you do something for yourself, that can really help you to improve your own health. But there's also a significant proportion, very significant proportion of people who have low exercise levels, and we should really try to move those people up into at least the moderate range. And this is now interesting with regards to the distress levels. So this is from a little bit older data, the 2008 National Aboriginal Torres Strait Health Islander Social Survey, and it asks about, or it shows us the proportion of people who self-report high or very high levels of psychological distress in people 15 years or over in 2008. And you can see here on the x-axis we have age again, and on the y-axis the percentage. And you can see that across the ages, actually, we have a significant number of people who report quite high levels of distress. So again, when we're faced with any of these persons here being asked to suddenly care for a cancer patient, we have to take that distress level that the patient comes into the caring role again into account when we meet them. This cause of distress question is very interesting. So people were also asked what was actually the type of stressor that they experienced, and you can see here that bad accidents or illness is actually the most common cause of that distress. So it could very well be that several of our carers are already within that category, and that experiencing bad illness or accident or problems with death of a family member or a close friend could already be causing that distress. Whatever comes first, we don't know. I guess there would be a longitudinal study needed to look at that more closely, but it's very interesting finding here. So supportive care needs, Gail has spoken to you extensively this morning about these. They commonly include information and coping with uncertainty. They include return to pre-treatment responsibilities, deal with social isolation, the stigma discrimination, and the life expectancy questions when faced with cancer. This was just a summary that we proposed in 2008. But really, Jimmy Holland, in his book Psycho-Oncology, has done it much more eloquently with the 5 Ds in 1996, I think. And the 5 Ds with regards to supportive care needs that he proposed are disability, dependency, disruption, disfigurement, and death. And so those are the things that our carers will have to deal with, as Jimmy Holland eloquently summarized. Suzanne Chambers and others reported in the European Journal of Cancer Care the carers' most common needs, a sample of 336, and this is across the population, so it's not just Aboriginal and Torres Strait Islanders. And you can see that the most common needs include addressing the fears about the persons with cancer's physical or mental deterioration, trying to reduce stress in the persons with cancer's life, accessing information that could help the person with cancer to get a better prognosis. Also, information with regards to the physical needs. They mentioned the impact that the caring has actually on their own life. So that's something that the previous slides, I guess, led you towards when, in considering when you meet a carer, making decisions about the life in the context of the uncertainty that we face, understanding the experience of the person with cancer, and accessing information that is relevant to your own needs as a carer or partner. So those were the most common needs that the carers reported. We did a small study with our brain tumor, with patients and carers of carers of patients who had a brain tumor a little while ago. And I thought I'd show you this slide because it is interesting. It used the standard version of the supportive care needs survey, so not the one that Gail developed, but the original form. And it gives you in pink the psychological needs, in green the physical and daily living needs, and in blue sexuality needs. And these are the needs of the patients. And you can see that we have the physical and daily living needs here, which are very prominent. But we also have a lot of psychological needs. And so how does it look in the carers of these patients? You can see here that the psychological needs actually lead here. And that's logical, isn't it, that while the patient is affected by the cancer and the physical symptoms will maybe be in the foreground, at least close to diagnosis, the psychological needs are the ones that really, really bother the carers, and that's what we need to assess in our carers. How can we use this data? I think that's something that I'm very passionate about, is that we not only collect that data, but that we start really using it and using it wisely for our programs to improve them. So one of the ways that we could use the data is, here we plotted the quality of life of the patients with brain tumors and their carers, and we compared them to the normative score. So you can see that 50 here is the mean, and 10 is the standard deviation. And this plotted the quality of life of the patients and the carers. And here you can see similarly that the physical well-being quality of life score of the patients is very low. The carers is reduced as well, though. Both report quite good social well-being, but then see this emotional well-being detriment in both the carers and the patients similarly. So really measuring this will help us to then target our interventions towards the area of most need. So we need to do that with our carers in the community settings as well, so that we can find out exactly where their needs are and then intervene towards those. And so the supportive care needs survey that Gail developed for the patients is the first step, and once we have one for the carers, this will help us as well. I think I'm almost close to my time, but I just wanted to mention briefly survivorship models of care. There are several around, and they all have the aim to improve the quality of care, reduce the long-term impact of treatment, and address survivorship needs. And they really plead for using evidence-based information when we provide our services. So, for example, the Institute of Medicine has summarized the 4 essential components of survivorship care: prevention of recurrent and new cancers, surveillance and assessment of medical or psychosocial late effects, treatment of those late effects, and coordination of caregivers. This graph just highlights all the particular needs of information of the patients, and it shows that for the carers, all of these are important as well. So what helps? We need to match the information to the needs. Patients and carers often have a preference to actually have some numerical presentation. So if we can show them where their supportive care needs are in relation to those of other people, it helps them to understand that that's something where they can really need support. They really need support, and that support could be given to them with regards to those issues. And we also need to explore the values attached to each of those states. All of these will be really helpful. And that was summarized by Edwards already in 2001. Lots of things can disrupt our communication with the carers. For example, if we don't choose the right timing, if we don't have the right setting, if we provide too little or too much information for that person, and if we are unaware of a solution, or if the person that we're talking to is very anxious at the time or very distressed, as we have seen, we be faced with a lot of carers that are very distressed, are passive, so don't really want to receive that information at the moment, are not paying attention, are listening selectively because they bring a package with them of personal history when they come to the session, and if they have about preconceived notions about the message or the sender. So I think that relates back to some of the speakers in the first session this morning. So audio taped recordings have been tried, communication skill training has been tried, decision aids, question prompt lists, care coordination, patient health records, and so on. So a lot of things that are necessary to really fit the information to the participants. Yeah, this was just one of my last slides. So how do we actually move from that assessment to actually providing much better support? This is an example by Klinkhammer et al. So what they did was they assessed at each time point the quality of life of the person and tracked it over time. So if you have a carer, you can actually assess their well-being at each of the time points, and you try to move them wherever they are towards the good range. So this is something that's really useful, and I think is something we need to do as a next step. Use of technology could also be useful. So thanks very much to all of our study participants who have helped us to put that data together. And I also wanted to thank Danette Langbecker, who has helped me with the slides, and all our staff at the IHOP group. Thank you.